Welcome to MedPro Education's GIT Masterclass, your complete guide to the gastrointestinal system. We've structured this series into 6 key sections: embryology, anatomy, physiology, pathology, medicine and surgery, and pharmacology. Let's begin with the most fundamental, gastrointestinal embryology. The GI tract arises from a primitive gut tube divided into foregut, midgut, hindgut. Foregut structures range from the esophagus to the duodenum at the level of the ampulla of Vater. Here, the pancreatic duct and common bile duct drain. The midgut begins from the lower duodenum to the proximal two-thirds of the transverse colon. In the 6th week, the midgut herniates into the umbilical cord. By the 10th week, it returns and rotates 270 degrees counterclockwise around the superior mesenteric artery, SMA. The hindgut stretches from the distal third of the transverse colon to the upper anal canal, ending above the pectinate line. To fully understand GI embryology, you must know its vascular supply, because many congenital and surgical conditions relate directly to these arteries. The blood supply of the gastrointestinal tract arises from 3 major arteries branching off the abdominal aorta: the celiac trunk at the level of T12 to L1, the superior mesenteric artery at L1, and the inferior mesenteric artery at L3. The foregut, including the esophagus, stomach, liver, pancreas, and upper duodenum, is supplied by the upper trunk, the celiac artery. The midgut, from the lower duodenum to the proximal two-thirds of the transverse colon, is supplied by the middle trunk, the superior mesenteric artery, or SMA. And the hindgut, from the distal third of the transverse colon to the upper anal canal, receives blood from the lower trunk, the inferior mesenteric artery, or IMA. These 3 arteries arise sequentially from the abdominal aorta and act as landmarks for both embryology and surgery. Many congenital anomalies, like midgut malrotation or volvulus, are centered around the SMA, the axis of gut rotation. During embryonic development, the ventral body wall forms through the coordinated folding of 3 regions: the rostral, head fold, the caudal, tail fold, and the lateral folds. Failure of these folds to close properly leads to ventral wall defects, which include gastroschisis, a right-sided abdominal wall defect where bowel loops herniate without any covering membrane. The intestines are exposed directly to the amniotic fluid, leading to inflammation and damage. Omphalocyly, a central abdominal wall defect where the intestines and sometimes liver herniate through the umbilical ring. These organs are covered by peritoneum and amnion, forming a visible sac, both present as visible herniation at birth, but they differ in location, covering, and clinical implications. Ectopia cordis, caused by failure of the rostral fold to close, leaving the heart exposed outside the chest. Bladder exstrophy, due to failure of the caudal fold to close, resulting in the bladder protruding from the lower abdomen. These conditions highlight the importance of precise embryonic folding during early development. Next, we explore tracheoesophageal anomalies, which result from incomplete separation of the trachea and esophagus during foregut development. The most common anomaly is esophageal atresia with distal tracheoesophageal fistula, TEF. In this condition, the upper esophagus ends in a blind pouch, while the lower segment forms an abnormal connection with the trachea. There is no connection between upper and lower esophagus. Clinically, newborns present with excessive salivation, choking after first feeding, coughing during feeding, cyanosis or bluish discoloration, inability to pass a nasogastric tube into the stomach. This is a neonatal emergency and must be identified early. Intestinal atresia is a congenital absence or closure of part of the intestinal tract. The two main types are duodenal atresia, due to failure of recanalization. It is classically associated with Down syndrome, trisomy 21. On X-ray, you'll see the classic double bubble sign, air in the stomach and proximal duodenum with no gas beyond. Jejunal and ileal atresia result from vascular accidents in utero, causing ischemic necrosis and segmental bowel loss. Atresia often present shortly after birth with bilious vomiting, abdominal distension, and failure to pass meconium. Hypertrophic pyloric stenosis is caused by thickening of the pyloric muscle, leading to obstruction of gastric emptying. It typically occurs in firstborn males and presents between 2 to 6 weeks of age. Key clinical signs include projectile non-bilious vomiting, palpable olive-shaped mass in the epigastric area, visible gastric peristalsis moving from left to right. On ultrasound, the pyloric muscle appears elongated and thickened. Surgical correction with pyloromyotomy is curative. Next is pancreatic abnormalities. The pancreas forms from two buds, a ventral bud and a dorsal bud. Fusion of these buds and their ducts forms the adult pancreas. Two major anomalies include annular pancreas, where pancreatic tissue encircles the duodenum, leading to obstruction or vomiting in newborns. Pancreas divisum, where the dorsal and ventral ducts fail to fuse. This can predispose patients to recurrent pancreatitis. You can see in the image that a normal pancreas has a main pancreatic duct, while a divisum of dorsal and ventral ducts. Unlike the pancreas, the spleen develops from mesoderm in the dorsal mesogastrium and is not derived from the gut tube. Let's quickly recap the key points of GI embryology and congenital anomalies. Foregut, esophagus to ampulla of Vater, midgut, lower duodenum to 2/3 transverse colon and 270-degree rotation. Hindgut, distal colon to upper anal canal. Blood supply, celiac, SMA, and IMA. Congenital anomalies includes omphalocaly and gastroschisis, tracheoesophageal fistula, choking after food, duodenal, jejunal, ileal atresia, vomiting after food containing bile, hypertrophic pyloric stenosis, persistent non-bilious vomiting and visible peristalsis, annular pancreas and pancreas divisum, cause of adult pancreatitis, spleen from mesoderm, not endoderm. These concepts are frequently tested and critical for clinical reasoning. In our next episode, we'll explore the high-yield anatomy of the GIT system.
Join us today and take the first step toward success.